So I will try to talk about the medical management of patients with germline mutations to complete the whole picture. So I will start with a case. This is a 31-year-old female with triple-negative breast cancer, a clinical T2N0M0 who has a germline BRCA mutation. She receives a neoadjuvant chemotherapy on Keynote 522 with anthracyclines, taxanes, as well as pembrolizumab, and undergoes a bilateral mastectomy. She chooses that because of the BRCA mutation, but does not have a PCR. And what would be your post-surgery treatment? And actually, you guys answered it very correctly, so I can just skip this whole section, but I will go over. So olaparib, pembrolizumab, capecitabine, the combination of pembrolizumab, capecitabine, or olaparib 1 year, and together with pembrolizumab for 6 months. So with this case in mind, what I would like to do within the next almost 14 minutes is review kind of the mainstream data that relates to adjuvant PARP inhibitors in germline BRCA mutation carriers. The second line has a typo. It should be metastatic PARP inhibitor data for germline BRCA mutation carriers, and also some special considerations for especially hormone receptor positive breast cancer patients. I will not have time. I will not have time to go into PARP inhibitor resistance, but I will mention it because that is a very important subject that challenge we now face in the clinic. So diving directly into our patient's case. So this is the adjuvant Olympia 8 trial that, as you know, included patients with hormone receptor positive or triple negative breast cancer. They could have received neoadjuvant chemotherapy or adjuvant therapy and then underwent surgery, and then were randomized to 1 year of placebo versus olaparib as maintenance therapy, with the primary endpoint being invasive disease-free survival and secondary endpoints, as you can see here, including overall survival. And going directly into the results, we see a statistically significant improvement by 30% or more in patients who received 1 additional year of maintenance olaparib after these germline positive patients completed all of their treatments. And as you know, and if there are any medical oncologists amongst you, it is not that often that we see a survival benefit in the adjuvant setting of breast cancer. So this is very significant. The initial outcome was reported at 4 years and then updated by Judy Garber at San Antonio in 24, as you can see, with a sustained benefit over 6 years. So treating germline positive patients with adjuvant olaparib does improve survival. But our patient was treated with the Keynote 522 study, and this is the schema of this study in the neoadjuvant setting, where the addition of pembrolizumab to standard of care neoadjuvant chemotherapy was tested, with the primary endpoint being PCR, as well as event-free survival as a co-primary endpoint, where patients either continued for 6 more months of pembrolizumab or a placebo, regardless PCR. I would like to mention here that capecitabine was not offered to these patients, olaparib was not offered, and the analysis was not done by germline BRCA status. I think this information is important. So looking at the results of this study, again, because of the interest of time, just skipping everything and directly diving into the overall survival data. In this study also, patients who received pembrolizumab had a significantly improved survival, as you can see here in this graph, as well as in the publication that was in the New England Journal of Medicine. So what do the guidelines say? The guidelines indicate that if you start with Keynote 522, regardless PCR, you ideally, if the patient tolerates, should continue with 6 more months of pembrolizumab. But the guidelines also say, well, if you have a germline mutation, you also should use olaparib. But the devil is in the details, and how to do this or whether favor one over the other is not there. So therefore, the mainstream medical oncology community tries to give patients the benefit of both because both improve survival. The question is whether you do them sequentially or you can combine them. And there is actually combination data. There's a lot of data for ovarian and other disease, but even for breast cancer, the Key-Link data that looked at the combination of olaparib and pembrolizumab that was just published by Hope Rugo, came out last week, does show that it's safe to do the combination. And again, I want to stress that there's no data on capecitabine for germline positive patients. So in this case, I think, like you all actually voted for, doing a combination of olaparib for a year and pembrolizumab 6 months would be the best choice. Now, sometimes some oncologists might finish the pembrolizumab for 6 months and then add the 1 year of olaparib. That would prolong the patient's adjuvant treatment a little bit, but that is an option as well. Now, I want to go back to the Olympia-A overall survival curve here. As you will remember, this study did not only include triple-negative breast cancer patients like in our case, but it also included hormone receptor positive patients. So what if our patient actually, we have a patient with hormone receptor positive breast cancer, and now the CDK4/6 inhibitors are used in the adjuvant setting. Now, what data do we have in terms of benefit in the adjuvant setting for the CDK4/6 inhibitors? We know olaparib improves survival. So for the 2 CDK4/6 inhibitor on the left side with abemaciclib, there is a survival benefit. So using CDK4/6 inhibitors makes actually sense in HR-positive patients as well. In the ribociclib study, there is statistically significant improvement in invasive disease-free survival, which is very meaningful. The overall survival is not mature yet. How do we put this together? And this is a whole other 1-hour lecture, so I cannot go into detail. But when we look at the guidelines, it really says for HR-positive breast cancer, use endocrine therapy plus minus CDK4/6. And if there's a germline mutation, also do olaparib because of the survival benefit. Now, moving on to the metastatic case, again in a BRCA positive patient, it's a 58-year-old female, had stage 2 right breast cancer at age 54, ER/PR positive, HER2 negative, high oncotype, sister with ovarian cancer, mother with breast cancer. She's germline BRCA2 positive, had bilateral mastectomy, chemotherapy, and anastrozole for 3 years because ER positivity, no CDK4/6, and then presented with bone and lung metastases, biopsy proven to be, again, ER/PR positive and HER2 negative. What would be your treatment choice? So endocrine therapy alone, endocrine therapy with a CDK4/6 inhibitor, or a PARP inhibitor plus endocrine therapy plus minus CDK4/6 inhibitor. And again, we are now in the metastatic scenario. So again, what data do we have to support one over the other? So these are the 3 metastatic trials with PARP inhibitors. The first 2 ones, Olympia-D and EMBRCA, compared olaparib and talazoparib to chemotherapy as single agent, and as you can see, showed a significant improvement in disease survival. The third study, BROCADE-3, is chemotherapy plus minus veliparib, which is not approved in the US. So we mainly treat our metastatic patients with olaparib or talazoparib. And what data do we have for this, our patient for CDK4/6 inhibitors in terms of outcome? The study on the left side does show that ribociclib does improve survival And with abemaciclib, we have 2 studies, one, again, showing a survival, overall survival, the other one only showing a disease-free survival benefit. So obviously, a CDK4/6 inhibitor is also an option for our metastatic HR-positive breast cancer patient. Now, and indeed, in the NCCN guidelines, for first-line, CDK4/6 inhibitors are actually recommended to be used in HR-positive patients, and when they progress or have endocrine resistance, then to use olaparib. But I'm here not to only show the NCCN guidelines, but challenge you a little bit, because there are, gray areas and zones in the clinic that we face, and also data. For example, many of us do ignore the study that was just recently published that showed that what if you use CDK4/6 inhibitor, not first line, but second line? Is the outcome the same? And the SONIA trial actually looked at that. When patients received the CDK4/6 inhibitor as first line versus second line, there was no difference in their overall survival. So for selected cases, you could actually use a CDK4/6 inhibitor second line. Further, again, going back to our germline BRCA2 positive case, the Olympia-D trial, for example, in a subsequent publication by Mark Robson, showed that the overall survival was especially improved when olaparib was used first line. And further, we also have data that in germline mutation carriers, CDK4/6 inhibitors might not work as well as in germline BRCA negative patients. And in fact, I'm not expecting you to read this, but I put this table together, looked at all of the publications with small numbers, but all of them actually showing that patients with germline BRCA mutations do not respond as good as germline negative patients to CDK4/6 inhibitors. So therefore, in our case, for example, we could use a CDK4/6 inhibitor. It's in the NCCN guidelines, but many of us do prefer using a PARP inhibitor first and then the CDK4/6 inhibitor because it's okay to use it second line as it does not decrease the survival. Again, in this case, I think I, for example, would use the PARP inhibitor first. So I think to summarize kind of the medical part here, I want to echo what all of our speakers said, that we cannot miss germline testing because it has major implications, not only surgical management, risk of other cancers, cascade testing, and family implications. It has major implications on medical therapy, and some of them can save lives. I have just shown you an overall survival benefit in the adjuvant setting and an improved overall survival in a metastatic setting if olaparib, for example, is used as first line. So we cannot ignore this, so we need to test these patients. I do agree that breast cancer requires multidisciplinary care, especially our germline mutation carriers. I just mentioned adjuvant olaparib improves survival. The optimal incorporation of pembro and CDK4/6 inhibitors is gray. It's not very clear in the guidelines. I think each patient requires a personalized approach, as well as personal decision-making. Some patients maybe do not want to take a CDK4/6 inhibitor because of the side effects. In the metastatic setting, again, I would favor a PARP inhibitor first line because subgroup analyses did show that if you use it first line, you can improve outcome. I did not have time today to talk about PARP inhibitor resistance, which is emerging because once a germline positive patient progresses on a PARP inhibitor or does not respond, we immediately revert back to standard chemotherapy. But the patient still has a DDR, and aren't there any other options where we can re-challenge a patient, maybe with PARP inhibitors, adding some other targeted agents such as ATR inhibitors, ATM inhibitors, V1, Pol theta, and others. In fact, we have a phase 2 study going on with olaparib plus ATR inhibitor, where we have patients who progressed on the PARP inhibitor when re-challenged with the same drug in combination with an ATR inhibitor, continued responding. So that is very promising. So with this, I would like to thank you for your attention.